Hello everyone, welcome back to MedRevision. Today we are continuing with primary causes of nephrotic syndrome, focusing on focal segmental glomerulosclerosis. So it's the most common cause of nephrotic syndrome in adults, especially people of African descent. It may be primary or secondary. Secondary causes are related with history of glomerular scarring, so patients who have a history of IV drug abuse, HIV infection, morbid obesity, hemolytic uremic syndrome, sickle cell, vasculitis, and cholesterol emboli, anything that causes or caused kidney damage. The history and how it presents. It presents with typical nephrotic syndrome features. So that's pitting edema. These patients may complain about weight gain or heavy legs, because edema is often on the legs. Their urine may be foamy, and then they'll have hypertension. For diagnostics, the definitive diagnosis of focal segmental glomerulosclerosis is renal biopsy. And in this one, unlike in minimal change disease, we can use light microscopy, which will show sclerosis and hyalinosis of affected glomeruli. We can also use electron microscope, which will show podocyte effacement. Pay attention that microscopy may appear normal if biopsy was of an unaffected segment, so take multiple samples to not misdiagnose it as minimal change disease. As I've said, with minimal change disease, we won't see any changes on light microscopy, but on focal segmental glomerulosclerosis, we will see changes. And we can also use immunofluorescence microscopy, which is sometimes positive for C3 and immunoglobulin M deposits. Management should be tailored according to the type, primary or secondary. Secondary causes should be treated accordingly, and for primary cause, idiopathic focal segmental glomerulosclerosis, high dose of glucocorticoids are the best initial therapy. If they are ineffective, other immunosuppressive drugs such as cyclosporin, cyclophosphamide, mycophenolate mofetil can be used. But keep in mind that unlike minimal change disease, focal segmental glomerulosclerosis response to glucocorticoids is really rapid or complete. So these patients often progress to chronic kidney disease. We can also use ACE inhibitors or ARBs to decrease hypertension and proteinuria. Thank you, and I'll see you in the next lecture.